Hi, it's Matthew Links, medical oncologist from Alice Springs Hospital, and welcome to this video in our series 5 Minutes of Remote Cancer Care on treatment with both chemotherapy and immunotherapy. It's aimed at health workers in remote communities caring for patients on these drugs. And the combinations we're talking about are conventional cytotoxic therapies and immunotherapy with checkpoint inhibitors. I'd like to start by acknowledging the Aranda people on whose lands I live and work, elders past, present and emerging from this community and all of the communities who get care from us. The goal is to focus on practical issues, both in the acute setting with symptomatic presentations and the setting of ongoing care. We want you to be aware of emergency and minor toxicity management, to understand different phases of treatment, different between induction and maintenance, be able to access support for unmet psychosocial, physical and cultural needs, as well as being to access additional information when required. The key task is to communicate in simple language what anti-cancer treatment is. We like the metaphor of cancer being a weed, like buffel grass, for example, that takes over country. So chemotherapy is like spraying weed killer. It poisons the cancer, but it does get into your normal body as well, which is why you can get side effects. And it works because your body, like country, bounces back. Immunotherapy works in a different way. Your immune system are like rangers who look after country by weeding the buffel. So immunotherapy increases the number of rangers to keep the cancer under control. Together, they fight the cancer two ways. Many cancer types are best treated by a combination of chemotherapy and immunotherapy, harnessing their different mechanisms of action. And there are some important differences between the two strategies. Immunotherapy tends to go on long term if it's working, whereas chemotherapy is often limited to 3 to 6 month courses because of cumulative toxicity. This means there's often a combined induction phase followed by maintenance with immunotherapy alone. The beauty of immunotherapy is the durability of the response, whereas the benefit of chemotherapy is its rapid onset. This means the intention of immunotherapy is focused on long-term survival. It's a tail in the curve of the long-term survivors that drives usage. Chemotherapy side effects are often more predictable. Immunotherapy side effects can be either minimal or severe. The difficulties are that toxicities overlap and add up, and that the management of toxicities is different. For example, diarrhea can be immune-mediated or cytotoxic, but the management of immune side effects rely on steroids. This makes life complicated. The biggest challenge is to think about immune adverse events. This requires realising the patient is on a checkpoint inhibitor, which can be difficult. There's a lot to be said for Googling unfamiliar drugs. And the second step is asking the question of any presentation, could this be an immune adverse event? Particular problems are subtle presentations such as adrenal insufficiency or hypothyroidism, as well as presentations where it's easy to blame something else and miss the reversible cause. Increasing cough in a patient with lung cancer and COPD is a typical issue, where it could be the tumour, it could be the treatment, or it could be the immunotherapy. And the final step is to access help and respond. One of the challenges with immunotherapy is that although for most patients the burden of toxicity is less than with the chemotherapy, toxicity is unpredictable, can affect any organ, and can be severe or life-threatening. Common issues are colitis, pneumonitis, hepatitis, and endocrinopathies such as thyroid or adrenal insufficiency. Patients on combination therapy are at risk of both chemotherapy and immunotherapy side effects. So conventional chemo side effects like alopecia, cytopenias, mucositis, nausea, vomiting, and febrile neutropenia, as well as the unpredictable off-target chemo side effects and the immunotherapy side effects. They're also subject to the global side effects of fatigue and chemo brain. The good thing with protocols that give induction chemotherapy with immunotherapy and then maintenance immunotherapy alone is the chemotherapy side effects are time limited for the first 3 to 6 months. Because of all these complexities, we have a low threshold in these combination patients for return to hospital. Now, febrile neutropenia is a difficult issue in remote communities. It's an oncological emergency, but part of the problem is you don't know if they're neutropenic and they may not be febrile if they're septic. If they do deteriorate, it might take a while before you can get them to a centre with an ICU. And for these reasons, it's best to work up anyone with suspected sepsis after chemotherapy as a suspected febrile neutropenia, treat them and repatriate them. It's worth thinking through how such an event would be managed, making sure there's supplies of antibiotics on hand and having an agreed strategy. The management follows standard sepsis lines of stabilisation, assessment, culture and early antibiotics, with a goal of antibiotics within 60 minutes prior to transfer or 30 minutes if they're unstable. A difference from most protocols in other centres is the use of vancomycin in view of the high prevalence of staph. A good toxicity assessment is about a good history focused on the functional impact. So for mucositis, it's the impact on eating. And for diarrhoea, it might be about the number of loose stools over baseline or the presence of incontinence, but also importantly about social functioning. The second thing is understanding what went wrong with the management plan. There should always have been a plan for prophylaxis and early treatment. So if symptoms are breaking through, what went wrong? Was prophylaxis given? Was rescue given? Was it too little, too late? Was understanding the barrier, or was it side effects? Identifying a better strategy is the key to improvement. Safe handling of hazardous drugs is an important issue, and there's a need to protect patients, family and staff. Particular challenges in remote communities include housing, access to toilets and overcrowding. The trick is to be sensible and not get paranoid. You don't need a hazmat suit and you can hug your grandchildren. The issue is with body fluid exposure, toilets, sexual contact and disposal of contaminated items such as continence pads, etc. So it's worth considering how this issue applies to this patient, and for further information consult the FAQ guide. If it's not possible to manage these issues in the patient's current environment, the question comes up if there's an alternative. Can they move to another family member's place, or do they need to come into town? Now, as with all cancer patients, a major role of primary care is providing ongoing support and identifying any unmet physical, psychosocial and cultural needs. This is an invaluable feedback mechanism. Identifying these needs, mobilising the support available in primary care and communicating information about unmet needs back to the oncology service is really helpful. There's a lot of additional information available. Particularly useful is the FAQ website. The best guide is information for the specific protocol, but there are general handouts on immunotherapy, chemotherapy and culturally safe care. Thanks to all those who've reviewed this site, and please email if you have any feedback or leave a comment on the YouTube channel. We really appreciate your feedback. These patients are incredibly complex, and a good relationship between primary care and oncology is the key to successful shared care. Thank you for your efforts. It really does take a village.